Welcome to the Healthcare IT Today CIO podcast. I'm John Lynn, the founder and chief editor at Healthcare IT Today, and I'm excited to bring you the most practical healthcare CIO insights and perspectives. We know your job is challenging, and we want to help you be more successful. And today's guest is a longtime friend of Healthcare IT Today, a longtime social media friend as well, and he's Dr. Dirk Stanley. He's the CMIO at UConn Health. Welcome, Dirk.
Thank you so much for having me. It's a pleasure to be here.
I knew I needed to have you on the podcast, so I'm excited. We finally made it happen. But for those that don't know you, tell us a little bit about yourself and UConn Health.
Sure. I'm Dirk Stanley. I'm a physician who works in clinical informatics. I'm the CMIO at UConn Health. I'm board certified in internal medicine. I have over 13 years of direct bedside experience. And gradually my career has taken me now into full-time informatics, where I am the CMIO in a large academic institution. We have clinical projects to work on, academic projects, research projects, administrative projects, a lot of things going on in healthcare. And I'm sort of the translator between largely the clinical staff and the IT staff. I sort of, I interface between both of those teams.
Yeah, that's awesome. And let's talk about informatics, because I think you're one of the most passionate people I know about informatics. Obviously, you publish a blog. We'll link to that in the notes so people can check that out. I mean, you share such amazing insights about what it takes to really do informatics that I think a lot of IT professionals don't understand. So what's maybe, one thing that many health IT pros don't really understand about informatics?
It's hard because I think it's not just about configuration and construction, if you will. Like, somebody sort of has to play the role of the architect, and it's very hard because very often I find clinical users, they know they have their needs, like they're trying to take care of patients and they have diseases to diagnose and treat, so they know what they need, but they may not be able to express it in a way that then the analysts and the other people who configure the systems do. So I fancy myself sort of a clinical architect, if you will. Like, I meet with the homeowner, talk to them about what are their needs. Like, do you want a 1-bedroom house, a 2-bedroom house? Do you need a wheelchair ramp? Maybe somebody is, disabled. Do you want the kitchen on the first floor, the second floor, the laundry? Somebody has to sort of work out those details, because eventually those users are going to live in this house and they're going to need to be able to do what they need to do. And so I take their needs, what are their, including even what's the budget, what's the, what's the time frame that you need this built, and then I turn it into blueprints that then I can hand over to the people who then actually do the configuration in the building. And that way it really helps there's somebody to be accountable for those sort of higher level designs. And that way, that the laundry is in the right place and the kitchen's in the right place, and you don't have a wall that goes, stairs that go to nowhere. I have to sort of incorporate all those things into the final design.
Yeah, I love the analogy. I was thinking of a different analogy, kind of the real estate agent that I had when I bought a house. There were a lot of things I didn't know about the process. I knew what the outcome was. I wanted to buy a house. I wanted a fair deal. I didn't want to be screwed by the other owner, et cetera. But what I didn't understand, for example, was I needed to go in and do an inspection before I signed that final escrow statement that says the house is mine, because we actually did that. And then the oven had been swapped out. Who knows what happened? I mean, probably some, robbers took it and swapped out this old one. But so we found that. And so the real estate agent saved us from things that we didn't know we needed, before they went wrong. It kind of sounds like an informatics person does that as well, because the doctor knows the outcome they need to get, and the tech people know how to implement some stuff, but there's something in between where it's like, how both of them interact with each other and the pitfalls that they could experience along the way. Is that fair?
Yeah, absolutely. That's a really good, somebody has to be that interface between the two and help avoid problems on both sides, and also I think it's really kind of also about translating so when the clinical people say, like, I just need something to help me around, And the IT people are like, what does that mean? Like, what is rounding? Are they spinning around or what, and you're like, no, that's going and seeing the patient, so there's a lot of like medical lingo that has to be translated so that the IT people can understand. And same thing when when the IT people are like, well, we're going to be taking, the switches down today. And, like the clinical people are like, what is that going to impact my surgery? Like, I don't, like,
Yeah. What are the switches? You're going to turn
what
off
are
the
the
light
switches?
switch? Is
Like,
it?
like, so, and even something as simple as just planning an upgrade and, doing a downtime, like there's so much work that goes into planning, like, okay, well, what's the right time to do it? What's the right, like, who needs to be notified? Is this going to impact the emergency room, the ICU, the operating, like, what is this going to do to billing? What is this going to do to scheduling? What, there's so much work that goes into making the decision to, when is the right time and who needs to be notified, and what are the downtime processes that they need to use while something is down. It's a lot of work.
Yeah. Another example to me is workflows. And I know that's another one of your passions, is trying to create that really great workflow. Can you give an example of like the process you go through, or how you really work through to ensure you get that really great workflow?
So I love talking about workflow. I'm thank you for for asking. This is something I'm really passionate about. Um, Good workflow for a clinical person feels right. It feels almost like somebody with your clinical specialty who like knows what you learned about diagnosing disease or treating disease. That's who configured the computer, and you use the computer and you're like, oh, I don't have to click for it. Like it's like very few click, and it's asking me all the right questions, and it's alerting me of like, it literally, I've heard people describe it as like you're walking down a street and you're not being stopped every 5 seconds, but like literally, like when you're hungry, all of a sudden somebody gives you food. When you're thirsty, suddenly somebody gives you a drink. When there's really something you need to know about, like, oh my God, they're doing construction, there's a big manhole, like you're like guided around the manhole, like, but it's like easy and it feels right. And it's like, it's almost like eating delicious food that that's been tailor made for exactly what you wanted. That's what good workflow feels like.
Well, that's
And
what a EHR out of the box does, right? Exactly what you described is.
well, it takes a little bit to get there, sometimes there might,
There's some work to do. Exactly.
there's definitely some work to do. But, it starts with understanding the needs. Like, what clinically are you trying to accomplish? Like, and not just what are you trying to accomplish, like, what are the other parameters? Like, where are you trying to accomplish it? Who needs the information? Where, when, how do they need the information? How does that impact your decision making? Like, there's so much, there's so much like cognitive process that you have to evaluate, like, because you always want people to have exactly the right information, not too much and not too little. You want them to have it in the right place, in the right time, in the right way, to the right person. Like, sometimes this has been described as the 5 information rights, or the 5 rights of information. Getting the right information to the right person, the right time, in the right place, in the right way is what makes good patient care happen. And it's not even just the doctors and nurses, it's also for the patients, right? Now with all the legislation around patient portals and open notes and stuff like that, giving patients the information to make better decisions, it empowers people, and they ask better questions. And there's been a lot of data to show improved outcomes and improved health from patients being more engaged and asking questions during their visits. So it's a lot to like kind of, you almost have to sort of think, who are all the people, and what information are they trading with each other and when, so that we can design those workflows to make all that happen.
Well, and I think the challenge I see looking at this workflow problem is that often you run into like competing interests. How do you approach that and kind of balancing those competing interests where, security is a great example, right? It's the easy one. It's like, well, security says we should do it this way. You're like, well, that's a terrible workflow, right? So, but there's lots of others, I think, right? Like, how do you approach that kind of competing interests of usability, amazing workflow, and some other competing interests?
Well, it's definitely hard. If I've actually mapped out like, who knocks at my door. There's users, there's patients, there's regulatory people, there's finance people, there's changing state and federal regulations, there's changing payer contracts, there's acquiring new services, and
And you didn't even say doctor and patient.
yeah,
Yeah.
all the people who use all these systems. So when you have that many people knocking at the door at the same time, this is where a very helpful tool is having good governance, right? We
Yeah.
listen to everyone who knocks, we meet with them, we talk to them, but we ultimately, most organizations then have to prioritize those, exactly to your point. You have to then really set priorities. What's top priority, what's medium priority, and what's lower priority. Even the lower priority stuff, I guess I just want to emphasize, is still important, but you have to sort of rank things in terms of importance and work on them, as fast and as efficiently as possible.
Yeah. And we had a conversation one time. I don't know if you remember it, in Boston. We were at an event, and you told me about some of the projects you had on your plate. And you're like, John, how do I prioritize these, right? And you're like, some of these, I can't remember the number. We'll just say 5,000, right? Whatever the number was at the time. You had this many, and you're like, and some of these are 6-month projects. So do I
Oh
do
yeah.
the 6-month project, or do I do the 6-day project because it's 6 days? I think that governance one is such a challenge.
It is, and a lot of people have. I'll just say I'm not sure there's any organization that has this totally worked out. Like, people are getting much better at it, but I can tell you, in the discussions about that, you have to weigh patient safety is always very
Sure.
high.
Priority.
That's usually one of the top motivators for a
Should
project
be.
being done.
Yeah.
But also the size and the scope of the project, how many people will be impacted, is important. Whether or not the project is related to maintaining the delivery of service, or if it's sort of a nice to have kind of project, it's also, there's a lot of factors that you have to discuss with the group, and people don't always agree. Sometimes people, have disagreements. And when they do, then, we have to often bring in, a third person to kind of help be the tiebreaker and stuff like that. It's
Yeah. Makes
a lot
sense.
of work. I would say, I would say probably about 20% of my job is just in evaluating projects and, trying to help provide expertise about, the priority for them. But I'm only one voice in a large
Sure.
chorus of people, right? So
Yeah. Well, and I think one thing I've learned in the CIO podcast and all the different CIOs, CMIOs that I've talked to is that the key is clear leadership from above with the mandate. So you can align that governance and those priorities with the leadership. And some organizations don't have that, which is challenging.
yeah, and you wanted to align with your strategic goals, absolutely.
Exactly.
But I think, I think most people in healthcare, though, have very similar sort of philosophies. Like, we're here for good patient care. We want,
Yep.
we need to maintain what we currently have. Not, and that's not just keep the lights on, but also make sure that things are continuously updated. This is another thing that I think sometimes people forget about. Once you build, let's say, an order set for treating pneumonia, it's great, but New England Journal of Medicine next month publishes oh, there's a better antibiotic for this. You got to update all that stuff. So, I'm constantly reading medical journals too. That's another thing that I do in my role, is
Sure.
making sure that what we have in the computer is fairly aligned with, what the up-to-date literature is. But I also depend on a lot of the doctors that I work with to help identify,
Yeah.
that stuff. So it's just a lot of work it's a lot of work building it, but then it's a lot of work maintaining.
Yeah, that's a fair point.
Yeah.
So as you look at your, all the work you do in health informatics, If you could solve just one healthcare informatics problem with like the snap of your fingers, the wave of your magic wand, and it would just be fixed, what would it be?
I think there's so many different facets,
There's
but
a
I think if I
thousand
had,
things you need. You need more than three wishes, huh?
well, yeah, I would wish for more wishes. Is that what I know? No, I think what would be helpful is having a better understanding of what informatics is, right? There's um, part of the challenge of being between those two worlds, the clinical and the IT world, is I think there's not always recognition of the importance of this role. Typically, it sounds like, the clinical people are like, oh, you're an IT person, what do you know about treating pneumonia, right? And then the IT people say, oh, you're a doctor, like, what do you know about, servers, and, or what do you know about data fields, or, like,
Yeah.
and, so you're sort of living in, between these two worlds. Um, and I think if I had one thing I could fix, it would be just greater industry understanding of the importance of all the people who do this work. Like and without an architect, it's very easy to build, a bathroom with a window that you can't reach. So, you never really can open it or close it, or, you know, somebody sort of needs to think about all these little details of how things are built. And, and I love what I do. I'm so passionate about it. I've met unbelievable people through my, what I do.
Sure.
But we definitely need more informatics people around the country, and they need to be more visible to, people on both sides of the fence.
Yeah. One thing that's been promising is I've seen a number of CIOs who were originally CMIOs. So I think that will help bridge some of the gaps at some organizations. So I think that's a good trend.
I hope so, but I'm equally discouraged that some of our famous websites that are still don't have CMIO in there when you're like putting
Yeah.
your job in. Like there's no CMIO anywhere there.
Uh,
There's
yeah,
some
that's fair.
pretty big websites, and here we are in 2021, and it's not even recognized as a job. So
Yeah.
it's
That's fair. I did have one CIO who was a CMIO as well, who said, "But we don't want too many because we still need the doctors," which I thought that was an interesting observation.
yeah,
It's a balance.
I understand. It's a commitment to to put a doctor to work in IT is certainly a commitment, but it's somebody really needs to be the architect, and
Yep. And the translator. I love
and the
that.
translator, right?
Yeah.
Yep.
So as you look at your career, what's the best advice that you've ever been given?
Um, for becoming a CMIO, you mean,
Yeah,
or
I mean, or that helps you in your career, that helps you find satisfaction in your job. Any advice?
uh, you know, I uh, I got the advice that informatics is not really about technology. It's not about computers. It's about information. And when I try to explain that to people, I'm like, and because often I get like, well, you're an IT person, right? Like, and I say, well, if you're on the clinical side of the fence, sure, you can call me an IT person.
Yeah.
But really, I think about information. I think about like when a doctor decides to treat pneumonia, they're in their head, they're thinking, you know, azithromycin and what dose and what route and what
Mhm.
frequency. Um, but that information is whether it was on paper or in a computer, it's information, right? It's information. Where it lives is kind of irrelevant, but it's
Uh-huh.
the fact that it's stored somewhere, right? It's almost like, it's much more about how you organize your closet than it is about, whether your closet is virtual or
Mhm.
um, real, right?
Yeah, that's a great example.
So if you've ever had the experience of trying to share a closet with somebody, like, people disagree over where to keep the socks, right? And where to keep the shirts or the pants or whatever. So you have to now, a lot of my job is about sort of organizing this virtual closet for, like, 1,000 doctors, like, are all the doctors going to agree on the doses of the medications and the time schedules, and are they going to agree where to find their notes and where to find the images and the x-rays and stuff. So you have to almost, it's very much about people. It's very much about the information that they share. I learn a lot just by listening to people talk, and
Mm,
not just about doctors talking, but nurses talking, MAs, OR nurses, office assistants and stuff like that. And it's fascinating to see linguistically the terminology that they use when they're describing their patient interactions. It teaches you a lot about how the information flows from one person to the other. There's a
interesting.
lot of information flows, whether they're verbal or electronic or on paper. It's about communication and how do people think about things.
Wow. That's some
Yeah.
great insight. I guess that's why we have two ears, one mouth. Is that what they said?
Yeah.
Listening and
Yeah. Yeah.
yeah,
That,
that's
I
great.
never heard that, but that's I'm going to write that one down. Yeah, right.
It's a good one. So, for anyone listening that may be aspiring to be a CMIO or maybe just became a CMIO or maybe a CIO who's trying to hire the right CMIO, what skills do you think that, they should work on the most to really be a successful CMIO?
So I don't. So for me, I like this almost happened by accident. I didn't really. I don't. I don't know. I think we've talked about this. I came from an IT background before I went to medical school,
Oh, really? I didn't
and
know
I don't
that.
know.
That's cool.
So I actually first worked for a small software company. I did Unix administration. I was actually the
Wow.
help desk person at one point. Like I was supporting a large group of salespeople who were at the time using dial-up modems to do like $1 million sales pitches of, for
Wow.
software. So I was the one they were, Dirk, like, why is the modem not working? Like, I'm like trying to like, sort through a patch panel and,
Yep. I
I,
was there.
I came from, yeah, right. So I came from that sort of background. And after college, I worked. I ended up doing. I was sort of a little burnt out, and I ended up um, volunteering at a hospital, and that's kind of the first time I started, learning about things. And they looked at my resume at that point, and they were like, "Oh, like you look like one of those computer people. Like we have a computer room here in the hospital. Why don't you go volunteer there?"
Uh-huh.
I started volunteering there, but I didn't know anything about healthcare, but I knew how to generate reports. I knew SQL. I knew how to, so I came from a data analysis background. Then they actually hired me full time as a medical data analyst. And I
Wow.
was that guy. I admit I was that nerdy, like with my spreadsheets and my, graphs, raising my hand in the middle of a large group of doctors going, can I just ask, why is the central line getting infected? Why is it never the line on the left or the line on the right? And they look at me like you have no idea.
uh,
You stay on that side of the spreadsheet. We'll do the doctor stuff, and you do the math stuff, and we'll. So I didn't understand what I didn't understand, right? And I kept asking more and more questions, and that's what eventually led me to medical school.
uh-huh.
And and I'll say as a final footnote, when I was applying, they, a lot of people told me, they were like, why is an IT person applying to medical? That doesn't make any sense to us. Like, we do medicine and you do computers. Like,
Yeah. You should
why
have
would,
studied biology or
yeah, why
anatomy
did
or
you, and I didn't have a good answer myself, right? But like, but eventually 2 years later, I got into medical school, and then 2 years later, now I'm wearing a white coat and a stethoscope, right? And I'm on my rounds down in New York City in Brooklyn Hospital. And I see people, I'm like, wait a second, you're typing data into this database A, and then you're printing it out and typing it into database B, and then you're printing it out again and you're typing it into database C. And you have no patient identity. You're creating duplicate records. So some poor data analyst, their graph, instead of looking like this, their graph is going to look like this because you're creating duplicate records. And they looked at
wow.
me like, no, no, no. You're a doctor. You have a white coat and a stethoscope. You don't know anything about IT. And I'm like, wait, like, wait a second. Like, just 2 years ago, you were telling me the other. I got that I was an IT person. Like, so I kind of fell into this, like, when both sides don't really understand what to do with you, you go into informatics, right? That's how I ended up.
Isn't there a lesson there though about the need to collaborate and maybe trust people's skill set and maybe not be so judgmental? I mean, that feels like an important message there.
we're all tribal, right? We all have our
Mhm.
tribes. We whether we realize or not, we subscribe to certain tribes, and we we make certain assumptions based on our perception of those tribes. So
Right.
it's okay. Like the medicine tribe didn't understand the IT tribe, and the IT tribe didn't understand the medicine tribe. So I
And
walked
now we need an
between,
informatics tribe who can understand both sides.
right, right. So I grew up in a multicultural household. That's the other thing I think that helped. I grew up, my mother is a German immigrant, and I grew up speaking German, but I
Uh-huh.
also, my dad is an American. So I grew up translating, between two cultures and two languages. So for me, this was always sort of like kind of my role, like just being that interpreter, living between those two worlds.
Yeah,
So I think that also probably helped me to some degree.
that's awesome. Well, Dirk, this was a lot of fun. I haven't seen you in person in years, so I'm glad we were able to at least connect virtually and I could share you with the Healthcare IT Today audience. And thanks everyone for watching. If you want to find more episodes of the CIO podcast, you can check them out at healthcareittoday.com. Danke schön, Dirk.